Okay. Today we will see about Duchenne's muscular dystrophy. And before that, I am going to introduce what is muscular dystrophies and how will be the problems in muscular dystrophy related children. So till now, in before lessons, we have seen some diseases of nervous system, that is cerebral palsy. We have seen some diseases with bones, like scoliosis, like another disease like absence of the limbs, or congenital talipes equinovarus, or dislocation of the hip, or flat foot. These are like related to majorly the skeletal system. Now the diseases are majorly related to muscular system. So among that, the first one is Duchenne's muscular dystrophy. So before going to Duchenne's muscular dystrophy in detail, you have to know what is muscular dystrophy. The origin of the muscular dystrophy is genetic inheritance. What is muscular dystrophy? Muscular means muscles. Dystrophy means they will be destroyed or they will be damaged. So whenever the muscle is damaged, almost the whole skeletal system is dependent upon muscular skeletal system stability or muscular system integrity. If the muscular system is weak, automatically your skeletal system will collapse. So the pathophysiology underlying the disease is progressive loss of muscle contractility, which is caused by destruction of myofibrils. Maybe any reason, if the muscle fibers are getting damaged, day by day the muscle weakness will be increasing in the patient and they will be having difficulty in the doing of movements. The rate of progression of myofibril destruction is variable according to various types of muscular dystrophies. The diagnosis of muscular dystrophy is confirmed by clinical examination and laboratory procedures. Like if you take EMG, electromyography, this is one of the clinical investigation which is usually done for the identification of muscular dystrophies. The classification of muscular dystrophies is like mode of inheritance, the age at what time it is happening, the dystrophy, how it is progressing, whether it is gradually progressing or suddenly increasing, how many areas it is involving, that is localization of the involvement, the muscle morphological changes, how the muscles are changing because of the disease, and presence of any genetic abnormalities or markers in the patient. Based on this, it is classified into various varieties. There are 9 primary classifications of muscular dystrophy, but commonly 6 most prevalent types exhibit initial clinical signs in infancy, childhood, and adolescence. Rest of them are majorly seen in the adults. So as we are discussing about pediatric population, our interest is majorly in the 6 conditions which are precipitated in infancy, childhood, and in the adolescence. So the 6 varieties which are majorly popular in pediatric population are Duchenne's, Becker's, congenital myotonic, childhood onset facioscapulohumeral disease, or Emery-Dreifuss. These are the 6 commonmost muscular conditions popular in pediatric populations. The Duchenne's is seen by 1 to 4 years. It is due to X-linked genome or chromosome which is involved. The Becker's is appears from 5 to 10 years. This is also because of the X-linked chromosome. The congenital muscular dystrophy happens by birth, and it is because of recessive chromosome. The congenital myotonic is also happening by birth, but this is by dominant chromosome. For example, if XX is one set of chromosome, XY is another set of chromosome. XX is dominant like male, XY is like female. So they based on the dominant genome is involved or the recessive genome is involved, the disease will change. The facioscapulohumeral, that means fascia, face, scapula, and humerus. So the major of the disease will be in the face-related muscles and scapulohumeral muscles. This happens in first 10 years. It can happen by dominant chromosome or recessive chromosome. The last one is Emery-Dreyfus. This is because of in early teenage it happens, and it is also because of the X-linked chromosome. So if you see Duchenne is in 1 to 4 years, Beckers is 5 to 10 years, and roughly Emery-Dreyfus is after 10 years. Like that you can see. So this is further explanation about these 6 diseases. Among that, the most popular and most commonest form of muscular dystrophy seen is DMD. DMD means Duchenne's muscular dystrophy. Duchenne is the scientist who first described about this disease. That's why we named it like Duchenne's muscular dystrophy. As we said, the cerebral palsy is approximately 4 to 6 out of 1,000 children. Like that, the Duchenne's muscular dystrophy is 1 out of 3,500 children who are born may have the DMD. The initial diagnosis typically occurs around 5 years of the age, although the symptoms are often seen on early 2.5 years, but the parents usually think that the child is growing, and because when the child is growing better, it will be good. But unfortunately, the child, as they are growing, disease will be increasing and they will become weak and weak day by day. The death of the child may occur at 20 years or approximately at the 3rd decade. There is genetic defect behind the Duchenne's muscular dystrophy and a missing protein in the muscle called dystrophin. So if this dystrophin is not present in the muscle will be self-destroying by itself and it will be losing its strength day by day. So the immediate question comes in people's mind, if you know that the child is going to die, then why to treat the patient? So my answer for this conditions is, if any stroke patient gets a stroke at the age of 70, how many years you expect that person to live? Maybe another 20 years or 30 years. So that person also is going to die. You stop treating that kind of person? No. Similarly, even pediatric population, if they are born with the abnormality and if you know that they are going to die, our aim is not to stop the death. Our aim is to improve the quality of life of the patient during his livelihood period. Okay, till the time he is alive, his quality should be good. Our quality of life should be good. That is what is our aim. So the clinical manifestations of this disease, examination of 4 to 5 years old child demonstrates the onset of classical features of Duchenne's muscular dystrophy and primary impairments of muscle weakness. So the primary most problem is muscle weakness. Second, the muscle looks big. There is hypertrophy in the muscle, but the muscle is weak. That's why it is called as pseudo hypertrophy. Pseudo means normal, or you cannot believe it. Pseudo, false hypertrophy. It occasionally affects in deltoid muscle, quadriceps muscle, forearm extensor muscles. Initial weakness is seen in neck flexors, abdominals, interscapulars, and hip extensor muscles, but most commonly affected muscle due to this pseudo hypertrophy is calf muscle. So the calf muscle, that is plantar flexors, especially gastrocnemius, is affected due to this pseudo hypertrophy. No limitations in the ROM are typically noted at the age of 5 years, but as the age is increasing, muscle tightness will be increasing. The gastrocnemius, soleus, and tensor fasciae lata muscles will become tight in the initial periods. So they look like this. You can see the calf muscle. It looks like big, but it is all false strength, pseudo hypertrophy of calf muscle, very commonest feature in DMD. Then the child looks like having abnormal posture. By seeing that, you see it as a sway back posture. This is because of the weakness of abdominals, weakness of gluteus maximus. The pelvis falls forward and the trunk moves backwards. So this is due to weakness of gluteus maximus and abdominals. The person will have sway back posture. And because of the interscapular muscle weakness, you can see bringing of the scapula, and they have, because of the quadriceps and hamstrings weakness, they do locking of the knee during the gait cycle and during the standing postures also. And slowly there will be increasing in the tightness of the calf muscles, which slowly increases, and patient will start moving on the toes. The muscles affected in DMD are shoulder girdle, pelvic girdle, and trunk muscle. So you can see here the shoulder girdle, pelvic girdle, and the trunk muscles. The mostly proximal muscles will be affected, and they will become more progressively weaker. So the proximal muscles are the most commonmost muscles involved, so that the proximal stability is gone, so distal mobility also will become weak. There is increased lumbar lordosis. We have seen in the picture. Winging of the scapula. Again, this also we have seen in the picture. And as the age increasing, the child may have scoliosis. That is abnormal lateral curvature in the spine. Infancy to preschool age period, there is no significant impairments, activity limitations, or participation restrictions. They are typically seen in infants and toddlers with DMD. So that means in infancy and toddlers up to 5 years, there is no major symptoms. The symptoms are seldom noted from 3 to 5 years. The mean age of diagnosis of the disease is 5 years. So they look like this. See the scapula winging, scoliosis in the spine, exaggerated lumbar lordosis, weakness of the abdominals, weakness of the gluteus maximus, pseudo hypertrophy. So this is all seen in the children with muscular dystrophy. So as you can see, the same child from the age of 1 year to 5 years, 1, 2, 3, 4, 5 years. So as the child is increasing, you can see the posture is becoming more and more abnormal. And the initial limitations in activity in Duchenne's muscular dystrophy typically occurs by the age of 5 years, and which includes clumsiness. That means because of the muscle weakness, initially the child will be doing the movements abnormally and they will fall. The ability to keep up with the peers while playing, like running, climbing, they cannot do because of the muscle weakness. When there is increased lateral trunk sway, the body will be moving side to side during the gait. This is called waddling gait. There is a Gower sign which is positive. Gower signs means when they want to get up from the floor, they go to prone position, they keep their hands on the knee, and slowly they get up by climbing up on the leg. I will show you I will show you soon in the PowerPoint. Stair climbing and arising to standing from the floor becomes more and more difficult as the child is going from 6 to 8 years. There will be increased base of support due to lack of muscle weakness. There is pronounced lateral trunk sway. This is called Trendelenburg gait and waddling gait. This will be seen in them. And you can see the Gower sign. The child will be going to the knee, take the support of the knee, and stand up from the sitting posture. So this is called Gower's sign. So again, like this, child go to prone, prone to quadruped, quadruped to the legs, keep the hands on the legs, both hands on the legs, then slowly move the hands up and they stand with the lumbar lordosis. So the clinical manifestations in school age period is toe walking because of the plantar flexor tightness, retraction of the shoulders with lack of so arm swing is decreased because of the retracted shoulders, increased fatigue in the walking, restrictive pattern of pulmonary impairment, that means breathing will become difficult because of the muscular weakness, and there will be progressively declining vital capacity in the lungs. So one of the major cause of the death in these patients is the lung infections. So the winging of scapula, the foot will go for plantar flexion and inversion. Majorly, the medical treatment, that is non-surgical treatment, is using steroids like prednisone, like difluzacort and oxandrolone, use of creatine. All these therapies, they will try to improve the patient's cellular conditions of muscle fibers. But the long-term use is not indicated by these medications. And physical therapy to prevent contractures and maintain mobility will be done. The surgical treatments like control of lower extremity contracture by releasing them, spinal stabilization for control of scoliosis, Achilles tendon lengthening or fasciotomy of the TFL and iliotibial bands, the posterior tibial transfer to the third cuneiform to reverse the equine varus deformity into dorsiflexion. Like that, they may do some modifications of the body structures to improve the functional capacity of the child by doing surgeries. But majorly the physical therapy is the commonmost thing any child will follow with DMD. The physical therapy management part will have examination and treatment. In the examination, the important thing which we have to notice, manual muscle testing or muscle testing by using handheld dynamometers or isokinetic dynamometers. Measure the range of motions, see which muscles are having tightness, how is the respiratory function, note down the respiratory rate, chest fall excursions, pulmonary function test findings, forced vital capacities. All these things in the chest has to be seen. And in the functional skills, see any scale like pediatric evaluation of disability inventory or school function assessment or Barthel index or VFIM. So any of the functional scales you take and you see them in the pediatric population. The classification system published by Vignos Functional Rating Scale for DMD will be useful to grade the child in which capacity they are. So this is the Vignos Functional Rating Scale, DMD. It is ranging from 1 to 10. 10 means they are completely in the bed, they cannot move out of the bed. 1 means they will be walking and climbing the stairs without assistance or without help. So progressively, they will be deteriorating from grade 1 to grade 10. So the PT management typically begins when the child is initially diagnosed at the age of 3 to 5 years. The goals is to provide family support and education, obtain baseline data on muscle strength and range of motion, monitor the progression of muscle weakness. So if you now you know that the muscle weakness will be increasing day by day. So you have to note down how is the muscle function capacity in the beginning, and slowly you will be start increasing the muscle strength and maintaining the muscle strength. Start with submaximal exercise program. Don't fatigue the muscles. Key muscle groups are included in the exercise are abdominals, gluteus maximus, that is hip extensor, abductors, and hip extensors or knee extensors. Cycling and swimming are excellent activities for overall conditioning of the body. Standing or walking for a minimum of 2 to 3 hours daily is highly recommended. High resistance and eccentric exercises should be avoided. Breathing exercises such as inflating balloons, blowing the bottles, maintaining pulmonary function can be included in the home programs. So this is the major thing which you have to focus, improve the muscle strength and respiratory capacity. the muscle strength, you can even think of using electrical stimulation to improve the strength of the muscle. One of the primary considerations in early management program of the young age children is to slow down the development of contractures. That means try to prevent the contractures as much as possible. The contractures are seen usually in hip flexors, plantar flexors, then hamstrings, hip abductors. In these muscles it will be seen. The range of motion program should be included stretching the following muscle groups like gastrocnemius, tensor fasciae lata, hip flexors and hamstrings. A home range of motion program should be advised and taught to the family. Each movement of the body should be repeated for at least 5 times with a 30 to 60-second holds in the stretched position, and frequency is usually 2 times per day of exercises. You can use even light sprints to maintain the joint positions. Like if you want to prevent plantar flexion contraction, you take an AFO and keep it throughout the day as much as possible and throughout the night as much as possible with some important breaks between. So that will maintain the length of the tendo achilis and which gives a good foot posture during the standing and walking. You don't believe me? The foot posture is the primary most determines whole the lower extremity kinematic chain. So if the foot is in plantar flexion, the knee go for hyperextension, the hip go for extension, and hip go for anterior pelvic tilt. But if if the foot comes and touches the floor, there will be mild knee flexion, the pelvis will be neutral, and you need not exaggerate the muscle activity which is required for the standing. Use of prone position at night also decreases progression of hip and knee flexion contractures. The falls and complaints of fatigue while walking becomes increasingly more frequent as the child goes from 8 to 10 years. A manual wheelchair should be considered as walking becomes a difficult task. As the progression of the weakness reaches shoulder girdles, propulsion of manual wheelchair will become more difficult. So you have to use the motorized wheelchair for the mobility like this. This is the example of motorized wheelchair to go from one place to other place in the town. In the adolescence period, that is in the teenage period, walking is usually lost. They cannot walk, or becomes increasingly difficulty. Use of manual wheelchairs or powered mobility becomes necessary during adolescence period. Possible surgical interventions for the management of scoliosis or contractures or to prolong the walking with the use of orthosis will be done. Cessation of independent walking usually occurs by the age of 10 to 12 years. You have to cope up with the disease condition. Positioning plays an important role in maintaining the contractures of the knee, hip, and foot. Continuation of standing through the use of standing frames, knee immobilizers, knee ankle foot orthosis is usually recommended to improve the standing capabilities. Like this is the walker, like that you have standing frame, or you have standing parapodiums. These all will help to improve the standing capabilities of the child. In the adolescence period, the cessation of walking in the late childhood or early adolescence, the emphasis of exercise program should shift from lower extremity to the upper extremity. So that means now onwards you have to start focusing on the upper extremity to maintain the upper extremity function. The range of motion program and gentle stretching of all the joints and muscles is recommended. Positioning program at night to provide comfort and prevent the skin breakdown will be good in the later periods. So when they are going towards adulthood, the major physical therapies continued the progression of disability with greater reliance on assistive technology. So they are more dependent upon orthosis or wheelchair or assistive devices. The environmental access and increased needs for assistance to carry out the routine ADL should be conducted. Breathing exercises, postural drainage, intermittent pressure breathing treatment should be included in the chest physical therapy program. Assistive ventilation with tracheostomy, so opening the trachea and putting the ventilator is recommended with respiratory insufficiency patients. A power controlled bed to allow the elevation of the head and to maintain the respiratory system should be considered. The respiratory insufficiency is a hallmark sign of potential the pre-terminal stage of DMD. That means the respiratory system is becoming weak and weak. That determines that this child may be going to die in near future because of the failure of respiratory system. So this is all about different varieties of muscular dystrophies and about Duchenne's muscular dystrophy. As a summary, the Duchenne's muscular dystrophy is a disease which is affecting the myofibrils of the muscle and which will cause progressive damage in the muscle, which leads to continuous weakness as the child is growing. There are majorly 6 varieties of muscular dystrophy. Out of the most common one is Duchenne's muscular dystrophy, which happens in 1 out of 3,500 live births. The major disease characteristics are it appears by the age of 5. It will be involving the muscles. There will be pseudo hypertrophy in the calf muscles. There will be Gower sign present. The standing will be sway back posture. Weakness of abdominals, abductors, and gluteus maximus is predominantly seen. The proximal muscles are more weak. So maintain the joint range of motion, muscle elongation, improve the strength of the child, increase the standing and walking capacities of the child by using assistive devices like orthosis or wheelchair or parapodiums or any mobilizing devices. So by this, we'll start improving the child life of a child life who is suffering from Duchenne's muscular dystrophy. So that is about the DMD. Any doubts, any clarifications you needed?